Great. It's a real pleasure to be here, and it's an even greater pleasure not to be on the committee. I spent about 20% effort, all unpaid, to be on this committee a few years ago. I'll just make one comment. I was really pleased to hear that from Janet that there's going to be initiative to identify research priorities in nutrition. We had an enormous number of research recommendations, and very few of them were implemented, and that is a problem in general for nutrition science. Okay, so as a chair of the prior guideline committee, I was asked to comment on various aspects. Only about 20 minutes. Actually, some of you have already stole my thunder because I was going to talk a lot about measurement, but I'll try to take a deeper dive into that. So this is what I'm going to cover, the 2005 process. This actually was 2003 when we started. The DRI values, the type of evidence we use, our decision making. And then I wanted to discuss some issues that I think the 2018 DRI committee should think about. I don't have answers for these. One issue is indexing DRIs to calories. It came up on two dietary guideline committees that I served on and was, I don't think, adequately addressed in 2003. And then estimating sodium and potassium intake, a perennial problem. So this is the conceptual model that that was our guidepost in 2003. At the one end, concern this is for any nutrient, not just sodium, potassium, but that there would be an estimated average requirement, and then where half of people, for some indicator, have met that goal, and then an RDA where virtually everybody has exceeded that and is at low risk for adverse outcomes related to lower intake. And then at the other end, an upper limit, which was before adverse outcomes occur. This is a very difficult model to apply to chronic disease relationships where there's a dose response. And we were, as our committee, had to use this model, and it was a challenge. We did not have a EAR or RDA. Instead, we have adequate intakes, which involved a fair amount of decision-making, which I think differed by committee and by nutrient. So these were the recommendations, DRI recommendations for sodium and potassium in adults. And so for adequate intake, we set it at 65 millimoles per day. I provide the milligrams per day equivalent and the upper limit of 100 millimoles. I'll go into the decision-making process. For potassium, we set the adequate intake at 120 millimoles, and the process for the AI was very different for potassium and sodium. There was no upper limit because we were making recommendations for a healthy population. So this is, I'm not going to spend a lot of time on this, but ideally, whether it's, medical therapy for prevention, you have trials of nutrient manipulation, reduce sodium and or increase potassium with hard clinical outcomes. We have virtually none of these, and so we have to use other types of data. And for the most part, we don't, and that's not unexpected. The other options are non-experimental studies, typically longitudinal observational studies, and those were actually discouraged from use when we were making our recommendations because of the numerous sort of design and interpretation issues. But we were encouraged to use experimental studies and typically trials with well-accepted surrogate outcomes. And actually, for sodium, potassium, blood pressure was the outcome, and it actually, I think, was a better indicator than many other indicators that have been used for other nutrients. If you look at vitamin E, it was prevention of hemolysis, which is not a particularly major public health problem or not a major clinical problem, but is nonetheless used to set dietary reference intake. So I thought we actually were better off than other committees because we at least had a well-accepted surrogate outcome. So I'll just now go through each of those four boxes. So there is no upper limit for potassium, and that's based on really no evidence of inability to excrete potassium in healthy persons, that you can consume, well over the 4,700 milligrams, and people with normal kidney function are going to excrete it. And we actually combed the literature, could not find evidence except under really unusual circumstances of individuals who developed some adverse medical problem related to too much potassium. The concerns, of course, are about individuals whose urinary potassium excretion is impaired, and those are predominantly chronic kidney disease and heart failure. There are also common drugs that impair potassium excretion: angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, potassium-sparing diuretics, and then, as I said, medical conditions. Now, diabetes, it might not be diabetes, it might be the kidney disease related to diabetes, and also chronic kidney disease, and I forgot to put on heart failure as another condition. DRIs for healthy populations, but we also have to acknowledge that we now have large numbers of people consuming these medications, and perhaps that's something the committee needs to, consider. What is the fraction of the older age population that is, with either the condition and or the use of medication? So here are the hypothesized adverse effects of inadequate potassium intake. And I just listed the ones that we considered: arrhythmias, insulin resistance, increased blood pressure, salt sensitivity, kidney stones, bone turnover, serum potassium levels. And the basis for the adequate intake was a combination of these four: increased blood pressure, increased people with low potassium intake also have a greater salt sensitivity. Individuals who have low potassium intake also are at increased risk of kidney stones and of bone turnover. So it was really these four, and I'll go over a bit of that evidence. So there are actually three observational studies. They all reach roughly the same conclusion, that at higher levels of potassium intake, there's a decreased risk of kidney stones. This is incident kidney stones, and this is from the Nurses' Health Study. And notice right here, this is in part, there are several sort of lines of evidence that pointed towards 120 millimoles or milliequivalent. So 119 millimoles, that was the median of this quintile. And there's similar evidence in the Health Professionals Follow-Up Study and a study from Finland as well. Then there's the issue of, and then in terms of trials, we actually did have one trial that was available that tested the effect of potassium citrate versus placebo on 57 adults with kidney stones. And if you see at the bottom, there was a difference in the stone recurrence with the potassium citrate group having a much lower incidence of recurrent stones. So this was, some experimental evidence in support of the observational evidence. Then there's blood pressure. So now I'm going to try, for the most part, saying here's the data that we had at the time. So there are many trials, over 20 trials, perhaps more now, of potassium supplementation. But very importantly, there was no dose-response trial at that point. It's not like we had, 40, 60, 80 millimoles of potassium. Paul Welton, who's here and can comment in his section, did a meta-analysis in 1997. And what was important about the meta-analysis is not just the average blood pressure reductions, but also the total amount of estimated potassium intake. And so, again, it's like 4.7, so it's really close to that 120. Notable, there was a greater blood pressure response in African Americans and in people at high sodium intake, and that's sort of based on more of a meta-regression type of analysis. And this is just a summary of or a figure that shows the average effect, not normotensives and hypertensives. So basically, this is what you commonly see with a lifestyle modification: greater blood pressure reduction in people who have higher levels of blood pressure, and that is net of control too. So there's also some evidence that potassium blunts the Pressor effects of increased salt intake, and this is a very elegant but albeit small trial done by one of our members of the DRI committee, Curtis Morris, and particularly in blacks who have higher blood pressure and who are salt sensitive, as in many studies. At higher levels of potassium, they experience a much lower rise in blood pressure in response to a bolus of sodium intake. And it's easier when you have these interactions to review the data than to describe the data. But there's also evidence, I think this is also consistent with the DASH sodium trial results where the relationship of sodium with blood pressure is blunted in the setting of the DASH diet, which happens to be high in blood pressure. Okay. So that was sort of the bolus of evidence on potassium, and many of those studies are sort of pointed towards 120. I will point out, though, that looking back, it might be that that's a bit on the high side, like some of the studies that use food frequency questionnaires. I'm not quite sure that that's the best way to estimate absolute intake, and I think you should look pretty hard at that number, 120, versus perhaps a somewhat reduced number. So moving on to sodium, these are the hypothesized adverse effects of inadequate sodium: increased plasma renin activity, increased insulin resistance, adverse lipid changes, and nutrient inadequacy, volume depletion in the setting of an acute thermal stress. And we did not think the data were particularly strong for plasma renin activity. Not that it does raise low sodium does raise plasma renin activity, but the clinical relevance was really quite unclear. We have a lot of counter-regulatory mechanisms to maintain blood pressure, and this is one of them. Insulin resistance, the evidence we thought was quite weak. Small studies and are often based on really driving sodium down to levels that really don't correspond to what individuals consume. I mean, close to like 10, 20 millimoles per day. Adverse lipid changes, we look for I was particularly interested in LDL cholesterol. If there's one surrogate outcome that makes a difference when it comes to lipids, that's the one that I focus on. There are a lot of diet-induced changes in other lipids, and I'm not as convinced, and nor was the committee, that they should be guiding policy. So a key issue was, can you achieve nutrient adequacy at low levels of sodium intake? And the answer is yes. In the DASH diet, you could achieve virtually every nutrient goal that had been set by the DRI committees, and also volume depletion. There was felt that this was an adequate buffer. You really don't need to have. I mean, most athletes don't even need to have excess sodium, but in order to maintain volume. But there are people who get exposed to acute stresses, and it might be worthwhile to have some buffer. These were the two reasons. So, as I just said, this was a particularly important piece of evidence that you could consume a diet that met all nutrient requirements, as not just the macronutrients, but also calcium, where there was concern that lower sodium might be associated with lower calcium intake. As for the heat stress issue, this was a study that I think was important to the decision making. It also highlights how even though you've gone through a systematic review, there's a need for other studies to help inform and provide important contextual information. So this was a study of individuals who are exposed to thermal stress and what happens to their sodium excretion, their fecal sodium excretion, the sodium or sweat excretion. And if individuals consume very high levels, well, they're going to actually excrete most of their sodium in urine. And if you reduce that, they'll excrete less. And if you really drive it down to close to the AI, they'll excrete even less. We basically adapt, to the sodium. And what I found interesting was there's a fair amount of sweat sodium that is also lost as well, and that goes down. And the same thing with fecal sodium. It's not a perfect study. This is not a crossover study, but it was a study that was done with three groups of individuals, and I think helped with our decision making. Okay, as for the adverse effects of excess sodium, these were the things we considered: blood pressure, increased risk of gastric cancer, increased protein excretion, CKD progression, osteoporosis, increased left ventricular mass, and the possibility of overweight, obesity. And, intriguing evidence, but really not enough to hold your hat on. So we focused on increased blood pressure as the indicator that would drive our decision making. And this is a well-accepted surrogate used by the FDA because of its strong direct relationship with CVD and stroke. So, we took a different, our approach to the evidence was we didn't have the benefit of an AHRQ report. We looked for, at least for sodium, we had several studies. Some were small, most were small, some, a few were large, that looked at studies that had 3 doses, because a lot of the DRI committee was focusing on dose-response relationship. So I'm just going to show you some of the studies. This is one of the earlier studies by MacGregor. This is a study of hypertensive individuals, and he accomplished changes in sodium intake, I think, through pills, sodium chloride, rather than direct feeding. And notice the lower level is around 50 millimoles, the middle level around 100, and then the higher level around 200 millimoles. And you see a progressive relationship. There's a study by Johnson. I don't think he was originally focusing on dose-response relationship as the primary purpose of his study, but he did, I thought, was a really intriguing study with 5 levels of sodium intake, and he documented again dose-response relationship with a greater, this I don't think is formally tested, greater response at these lower levels of sodium. And there were several other, groups in this study: hypertensive, isolated hypertension. And here's another group. They all serve the same thing, in these individuals, rise in blood pressure with increased sodium intake. So the largest study to date is the DASH sodium trial, also the most diverse population, and importantly had pre-hypertensive or hypertensive. You see this dose-response relationship: higher sodium intake, higher blood pressure in a typical American diet, but also in the DASH diet. And we did test for nonlinearity, and there is a steeper rise here between 1,500 and 2,400. That's based on the average sodium excretion in the urine. In these at 3 different levels. And that was a crossover design for sodium. So it was tough decision making on how to set the UL because of this relationship, progressive dose response that really didn't align with the conceptual model. So I'm not sure it's necessary to read through this. This is pulled directly out of the abstract. Maybe I should, just so we're on the same page. Because the relationship between sodium intake and blood pressure is progressive and continuous without an apparent threshold, it is difficult to precisely set a UL, especially because other factors, weight, exercise, potassium intake, dietary pattern, and alcohol intake also affect blood pressure. And then I mentioned that there are certain groups who appear to be more sensitive, but you cannot identify individuals, only groups. Okay, now I'm going to move on to the issues that I think the current DRI committee will be thinking of me about, or should. So calories. I think there's an important issue about whether there should be some type of indexing. This might be a way to add a range into your deliberations. So why consider indexing? So scientific, what is the optimal metric to define the exposure when you're looking for risk relationships? Then there's what I think is very important is pragmatic. It is difficult to keep a sodium below the UL at high calorie intakes, and also to achieve the AI for K at low calorie intakes. And the other thing to think about is when people eat, if you have somebody who is eating 1,500 calories and somebody who's eating 4,000, they're typically eating at the same table, and you don't have like different products based on calorie intake in order to eat nutrients. So, I mean, there are incredible practical, issues related to having it indexed as opposed to having absolute level. And of course, there's a tradition. All prior recommendations use absolute. So I just wanted to point out that one of the that the tight relationship between sodium intake and calories, and it was less apparent to me when I was on the committee, but these are average intakes by age in boys and girls. Boys men are in the orange, and girls in the yellow. And what you see is in men this rise to about 50 that goes down. And interesting, I don't have data above 70, but I think it probably goes down even further. And this high intake of sodium likely reflects calorie intake, and I'll show you. This is the calorie intake, which is virtually identical, okay? I mean, just like overlapping. And I think it's more so for sodium than for other nutrients. I'll show you a correlation matrix where the correlation is about 0.8 for sodium and about 0.7 for potassium. Yeah, this is it. So the relationship between calories and sodium, the correlation is 0.81. I think this was from some analysis we did in Haynes, and then for potassium, 0.73. All right, so the upper limit, though, despite this issue of is really based on absolute, and it's not indexed to calories. Okay, so DASH sodium trial. Even though sodium results used to set guidelines on absolute intake, the trial tested sodium density. So this is really important. So we tested 3 levels: higher, intermediate, and lower. This was the average urinary sodium excretion. But what's interesting, we actually tested densities, so there's a lower, intermediate, and higher. And so it's somebody who is consuming 1,600 calories, let's say a sedentary older woman, the high intake was 2,700, which is less than the intermediate level in somebody who is 1,600. So you have different levels of sodium. The same level of sodium intake could correspond to different levels because of calories. Okay, so this is how it's best presented: lower, intermediate, and higher. That's the graph I showed you earlier. This is what I have used in my slides, but I'll confess I was wrong. I really think that the best way to do it, sometimes this pointer does not work, should be this: sodium density. That is what we tested. We didn't test absolute amounts. We tested sodium density in DASH sodium. Okay, and some results that will be published shortly. I think there's also a scientific element that needs to be appreciated. I was really interested in what is the relationship between lower, intermediate, and higher levels of sodium intake by level of calorie, and it appears to be much steeper for people who are consuming lower levels of calorie and less steep in individuals who are consuming higher levels of calories, and this is the level of systolic blood pressure by absolute level of sodium intake. So this paper was accepted for publication in Hypertension and will be coming out shortly. So measurement, I think this is one of the most important issues. So issues to consider: high inter-individual variability in urinary sodium excretion and its implication, estimation of individual versus group intake, the role, if any, of spot, overnight, and time collections. Can we use it to estimate absolute intake or change? Estimation of dietary K intake from urinary K excretion. People sort of think of that K excretion as a valid proxy, but I question that. And then factors associated with low sodium excretion. So let me just quickly. So this is a study done in cosmonauts where individuals were fed 200 millimoles per day, and this is the average urine. This is the urine excretion on a daily basis, and you can see despite a fixed intake, there's massive variation. So what does an isolated value of 100 correspond to? Does it correspond to mean, or does it correspond to variation? And I think that's one of the issues that could be explaining some of the paradoxical results when we use one value that is low, and does that correspond to average or just a person with extreme variation? This is evidence from Connie Weaver's study in adolescent girls. This is a single individual who was being fed close to 150 millimoles. And again, you see these spikes, 24-hour urines collected on a daily basis. So if you get a value of, in a population of, let's say, 70, does it again mean that that's the average of that person, or did you happen to sample that person who has more extreme variation than other individuals? So there are ways to, there are options to estimate usual intake of individuals, and the optimal, but rarely done because of logistic issues, are multiple high-quality 24-hour urines. We can use single or poor quality 24-hour urines, spot, overnight, or time, 24-hour recall, food frequency. But those are problematic. You can use high-quality single urines to estimate group intakes, and I think that's what Molly will show later. So there are methodologic issues in cohort studies. This is part of the reason we didn't have only a few cohort studies when we did our report in 2003, but we were really quite skeptical because of measurement issues, although we hadn't cataloged them, I think, as systematically as was done. So I'll just point out there is the potential for reverse causality, systematic error to be concerned about, and also the potential for residual confounding. And importantly, and confounding related to variables in the formula used to estimate 24 hours. So there's urine creatinine, age, et cetera. Point that I want to make about potassium, the percent that is excreted is not 100%. It's not even 90%. This is in a DASH trial. It's about 60 to 70% in whites. And interestingly, is about 50 to 70% in blacks and differs by diet. Okay, so I always sort of really careful about using urine potassium excretion. So this is my last content slide. So suggestions to the committee. So I think you need to explicitly address the issue of calorie adjustment for sodium and potassium and other nutrients. Okay. Secondly, we didn't really focus on measurement issues, but I think in order to interpret the evidence, you're going to have to take a deep dive, deeper than I think other committees have. So the first one is estimation of K intake from K excretion. Second, estimation of individual versus group intake from urinary excretion. The potential roles of partial urine collection, spot, timed, overnight to estimate usual sodium intake and potassium intake. The accuracy of urinary excretion as a proxy of intake in the setting of hypertension, subclinical disease that impairs sodium excretion. So I do think the 24-hour urine collection for sodium is the gold standard in healthy populations, but we have not done balanced studies in populations where there's impaired excretion. Okay, so I think that's an important issue, and also that could contribute in large population studies to, some aberrant findings. And finally, interpretation of low sodium intake and excretion. What does it mean beyond just low sodium intake? And I'd like to thank the other members of my committee who gave 20% efforts, all gratis. Thank you.